My name is Dr. Tunde Lalude. As Dr. Nobowale has said, I've now been in Nigeria for 4 months after spending 26 years in the National Health Service in the UK, where I trained as a colorectal surgeon. When he told me we were coming to this event today, when I looked at the invitation, it certainly was something which is very personal to me. I can empathize with Eniola because my sister died at the age of 27 years from bowel cancer. So I've been on a journey. My association with colorectal cancer is therefore both on a personal and a professional level. Now, one thing that has been clear is when we were in medical school, there were very few cases of colorectal cancer, and that was, in Africa in general, that was authenticated by the World Health Organization. However, to me, what has always been one of the most interesting statistics is the fact that the racial group in the United States with the highest incidence of colorectal cancer is African Americans. And most African Americans came from West Africa. They were exported to the US many hundreds of years ago as slaves. Now, what it means when you look at when we had a traditional lifestyle in Africa, in Nigeria, and we had low rates, and you had a high rate in the US, what it told about the genetics is the same. So African Americans and people in Nigeria, we share the same genetics. What that told us was that if you expose our genetics to a Western lifestyle, that predisposes us to having certain rates of colorectal cancer. And I think that is now being borne out because I think most of us in medicine, if not in the general population, are very clear that there are increasing numbers of people with colorectal cancer. One area where it differs between Nigeria and, say, the UK is the demographics. Like, I think Eniola's husband was 30-something. My sister was 27. I've seen many patients. The youngest I've seen was when we went to a patient who had an operation for rectal cancer at the age of 14. And I remember when I was, after my youth corps, I worked in Ondo for about 10 months before going back to the UK, and we saw a patient at the age of 16 who had bowel cancer. Obviously, at that time, I didn't have the skills to deal with the problem. Now, one thing about bowel cancer is that it's very stage dependent. Therefore, we stage it stage 1 to stage 4. Stage 1, the cure rate is about 95 to 100%. Therefore, what we're trying to say is that obviously the earlier you catch it as a disease, the better the chance for cure. So going from stage 1 to stage 4, the earlier stages have a better 5-year survival, as we call it in cancer surgery, than the latter stages. And another thing about bowel cancer is that the evolution of bowel cancer is actually very slow. So it's generally accepted that from a clean colon, that's from a colon with nothing in it, to getting bowel cancer takes almost 10 years. Okay, and that gives us an opportunity. And we do know that screening, because bowel cancer usually starts as what we call a polyp. A polyp in itself is a little growth in the bowel, which is not a cancer. It is what we call a benign lesion. And it grows over a long period of time, changes take place, and then it turns into a cancer. But what is clearly shown in the literature is that if you look for and remove polyps, it is protective against getting bowel cancer. And that is the rationale behind a screening program. The idea is to find things early and remove them. And we do know there are a number of symptoms. A lot of patients in the early stages will have absolutely no symptoms at all. But we do know that there are certain symptoms which we should aggressively, and I emphasize aggressively, investigate. So patients who have rectal bleeding over a certain age. So if you're 20 years old, you probably might not scope, but certainly someone who's 40 plus we would investigate aggressively. A change in bowel habit. Now, when I was in medical school, we were told constipation, alternating constipation, diarrhea, but there are studies that show it's actually diarrhea is the commonest presentation for change of bowel habit. Pain, weight loss, unexplained iron deficiency anemia. So anemia, which is shown to be due to a lack of iron, should be investigated. And what we'd normally do would be to perform a gastroscopy, having a look down and having a look up from behind. Now, there are a number of treatments for bowel cancer. Surgery is the accepted curative treatment, but there are other treatments which we use, particularly when it's advanced. So we have situations where people with advanced rectal cancer normally give them radiotherapy and chemotherapy first. And in some patients, the tumor actually disappears completely. And there are now some people who would say, well, in such patients, you wouldn't operate, you just wait and see as to whether they redevelop. One of the problems we have in Nigeria, obviously, is that it is actually quite expensive to treat properly. So in terms of doing the investigations, the colonoscopy, the MRI, the CT, which are needed to evaluate, the surgery that we need to treat, the chemotherapy. In fact, I'm not really aware of any properly functioning radiotherapy units in Nigeria. And for us, that's a big problem, because for the patients who are advanced, you can operate, but the chance of it coming back is almost 100%. If it's advanced and you do an operation in the rectum in particular, the chance of it coming back is about 100%. So there are other things that you need to do first. And the problem is that what we call recurrent disease, when you have the cancer coming back, it's inevitably fatal. And that's what happened to my sister. She was quite advanced by the time she was diagnosed. And when I look back now, because things have moved on hugely now, and I look back and think, wow, she potentially could have been cured with the modalities that we have available today. But the problem is that there is a serious shortage, I think, particularly of skills, of equipment, of knowledge. I mean, I personally have probably treated hundreds of patients, and we've cured about 70% of them of the disease. So training, medical personnel, the equipment that we need are all things that we need to push for. And I think that an organization like this that could be involved in increasing the awareness and telling people not to literally sit on their symptoms. Once you're of a certain age, if you have these symptoms and it's more than about 4 weeks, you must see your doctor, and do not be fobbed off. You must be investigated, because that's the only way for us to reduce the problems that we're having with this disease. But inevitably, in healthcare in Nigeria, everything comes down to money. The problem we have is that we don't have enough money pumped into healthcare. So nationally, we probably spend about 3% of GDP, and of what is a relatively small GDP. So to put that into context, in the NHS, we spend about £110 billion a year on healthcare only, bearing in mind that they have a population of about 67 million. And we have a population of almost 200 million. So you can see the difference. They're spending what is probably more than our entire national budget just on health. And unfortunately, in the modern world with the technology, that's what we will need. Maybe not 110 billion, but we certainly need to be spending a whole lot more than we're spending now. So for organizations like this to be able to raise money and to be able to do things on a charitable basis, making available investigations and treatments that would otherwise be outside the reach of the average person on the street, is a massively beneficial thing for us as a country. And we're going to have to depend, because not many countries in the world depend on out-of-pocket expenditure to fund healthcare. In fact, for a lot of the bills that you get in Nigeria, the average guy in UK on the street cannot pay. You can't pay how many million naira equivalent to how many thousands of pounds. How much do they earn? And for us, where we're poorer in this country, to have to put your hand in your pocket to pay for healthcare expenditure is a massive problem, which hopefully we will address through universal insurance schemes in due course. But I doff my cap to Eniola. I think this is an absolutely fantastic initiative, and certainly we would be most happy to partner with this organization and give the benefit of the skills that we have to take this forward. Okay. Thank you.